All right, everybody. Welcome. Welcome back to the November edition of the DuPage ROSC presentation series. My name's Jared. I am your ROSC coordinator. Good to see everybody. If we could just make sure everyone remains muted until it's time for questions or comments, that'll help us kind of cut down on some interruptions. If you want, you can go ahead and put your name and contact info into the chat. That helps us take attendance. And yeah, I'm going to share a couple things before we get to our presenter for the day. So allow me to share my screen real quick. Okay, just a few things that are coming up. I know as we get into the holiday season, a lot of stuff's happening. A lot of people are on vacations and things like that, but we do have some stuff going on. So next month, Wednesday, December 11th from 3 to 5 p.m. Is our third annual ROSC holiday party. I cannot believe we have made it to year 3, but here we go. So December 11th from 3 to 5 p.m. If we could make sure everybody stays muted, please, that would be very helpful. Or I can mute you. Um, so December 11th, 3 to 5 p.m. Come join us in person at Serenity House. This is going to kind of take the place sort of our usual ROSC Council meeting. We will have a short online component to go over a few things, but we really want to try to get people there in person. So hope you can join us on that day. I'm still running the ROSC Winter Coat Drive probably through the rest of the month for donations to the People's Resource Center. We've done this before for them, as well as some sock drives and other things. Great organization. I'm sure most of you know them. I am having donations dropped off at Serenity House Monday through Thursday, 9 to 5-ish. But if you want to make separate arrangements, you can go ahead and reach out to me and I can make sure that we do that. In January, just booked the next ROSC and RCO game night. So this is the third one of these that we've done. Very, very cool. At Serenity House, we put a bunch of video game systems, board games, cards, food, you name it. I usually also have a little trophy for the winner of the, I guess, best gamer of the evening. So please join us that Saturday, January 25th, from 6 to 9 p.m. Couple other events, December 5th, coming up. Our partners with at the DuPage Health Department and Impact DuPage are doing a learning collaborative, just kind of an overview of substance use trends in our county, as well as stuff about medications, medication-assisted treatment, all that good stuff. I think there is a CEU available, but yeah, register for that one. And last but not least on the events, today at noon, the wonderful Glenbard Parent Series. They always do really, really great bookings, great guests, great authors. And today, November 20th at noon and at 7 p.m. via Zoom is Nick Sheff, who's written a couple of different books, both solo and with his dad, and was also played by, I believe, Timothy Chalamet in the movie version of that book. So hope you can join that. That should be a really, really cool conversation. And I'm going to go ahead and stop my share. And I'm going to turn it over to our guest speaker for the day. So we have had this guest, Don Mitckess, a couple of times for presentations. He is the Director for Clinical Strategy over at Relief Mental Health, as well as an LCPC and a CRADC. I believe the last time he was here, he was talking to us about TMS, which is transcranial magnetic stimulation. Today, we're going to be talking about something that has a lot of intersection with not only mental health challenges, but also for us as people who deal with substance use challenge clients, there's crossover with this as well, which is eating disorders. So I will admit that this is a blind spot for me personally. This is not an area that I have had a lot of experience in. And so I think that that's all the more important that we have these type of presentations so we can kind of get out of those blind spots. So Don, I'm going to stop rambling and I'm going to turn it over to you. And yeah, we'll get going.
Excellent. Thanks, Jared. And thanks for having me today. I appreciate the opportunity. This is a clinical area that's near and dear to my heart. I spent 8 years at Alexian Brothers Behavioral Health, working with the Center for Eating Disorders there as their clinical outreach representative. And it's one of the few places in Chicagoland. Alexian Brothers and Linden Oaks are the only places that offer St. Joe's in Chicago, an inpatient eating disorder unit for acute care. So when folks get to a point where their disease has progressed to the point where there's medical issues, resultant from the behaviors. There's just not a lot of resources in the community. So I'm glad Jen's here. Make sure you jot down Jen's information. Without a doubt, she's going to be a great resource for you if you're looking for a treatment resource for an eating disorder. Having worked in the addiction field for a number of years, like Jared, it was a blind spot for me for a long time too. It's there's a lot of crossover between the two disease states. So the idea is being a good identifier, because it's amazing how many people who will present with a substance use issue that also have an eating or a feeding disorder issue. So the idea here is to arm you with a little bit of information about what those disorders look like, and some questions to ask, some observable signs, right? Because guess what? They don't necessarily tell you right up front that they have an eating issue. And unfortunately, you may find yourself playing what we call clinical whack-a-mole, where you might they might get sober, go through detox, and all of a sudden these other behaviors just ramp up and take off. So being a good identifier, being able to treat these things concurrently can really be, for lack of a better term, life-saving, because it really is potentially life-saving. So I'm going to share, let's see. I think this is the right one. Let's see. Is this the right one? It is. I just got to get into. All right. It's been a while since I've had to use Zoom, but I am here for it. Here we go. I think. How about we start at apologize, making you dizzy for a minute here. We're going to go to the beginning. There we are. Eating Disorders 101. So we're, the objectives we already kind of talked about is talk about some of the common eating and feeding disorder areas, the risks that come along with it, and why it's important to have particular components to the treatment of an eating disorder that are a little bit different than what we see in the addiction area. So in the general population, there's something of a continuum in regards to eating problems that range from the fairly routine body dissatisfaction or normal discomfort with, boy, I'd really like to lose 10 pounds, right? That can progress into disordered eating or developing an unhealthy relationship with food. And that can also then progress to a diagnosable eating disorder. Just because someone there's some additional components aside from just the food when it comes to the difference between disordered eating and an eating disorder. And in between these categories, we have, things that will cause this to progress, right, from one end of the spectrum to the other. So with body dissatisfaction or normal discomfort, that can lead to someone dieting. And boy, oh boy, are there just tons of different diets or theories about how to lose weight, most of which, probably 90% of what you see out there, is completely unhealthy and will result in rebound once that dieting plan stops and regaining the weight that was lost. From disordered eating, when you add a component of obsessiveness, that's when things tend to progress to a diagnosable eating disorder. So you're adding more of a psychological component to the dynamic that will tip the scales into something that's an actual diagnosis. All right, here we go. Some stats. All right, so before the age of 25, 1 out of 5 people with a diagnosable eating disorder will pass from their behaviors. This is eating disorders next to and recently overtaken by opiate use disorder. Eating disorders
Is that a lot of people on today?
Have the highest mortality rate, right? So when you start having conditions where people are restricting their food intake, or changing the way that they process the food that they do intake, it's going to result in medical issues. And we'll talk a little bit about those. So again, the mortality rate is 12 times higher than any other cause of death for 15 to 24-year-olds. And then the male mortality rate, here's the issue with male mortality rates when it comes to eating disorders, or males in eating disorders in general, is we don't have quite the robust amount of data that we do for females with eating disorders. It is wildly underdiagnosed in males. Dude, go to any high school and look at any wrestling team, and you will see active eating disorders in a certain percentage of them. I mean, it's a lot more prevalent than any of us are really identifying at this point. So, but we have a lot more data, and a lot of the studies are, as opposed to every other disorder, this is the one disorder area that we have more information about women than we do men. Generally speaking, up to 10% of people with AN, stands for anorexia nervosa, will die within 10 years after contracting the disease. Within 20 years, that goes up to 20%. And much like substance use disorder, there's only about a third to, less than half of the people will fully recover, right? And here's one of the differences that you'll find between the eating disorder treatment community and the substance use treatment community, is that we're pretty sure in the substance use community that recovery is a lifelong process. It's a disease that needs to be managed over a lifetime, right? You have to be constantly vigilant. In the eating disorder treatment community, there's no agreement between recovery and recovered. So you have to be in some ways careful when you are interacting with an eating disorder treatment program or therapist, where they stand on the issue, because it can lead to some debates. But that's all I'm going to say about that. Anyways, so here, generally speaking, there's three major categories of eating disorders: anorexia nervosa, bulimia nervosa, and binge eating disorder. There's a couple of smaller subsets, which are ARFID, avoidant restrictive food intake disorder, and the general category of this eating disorder behavior does not fit neatly into either of the other four categories, which is the old NOS, or otherwise specified feeding or eating disorder. So anorexia, what is it? It's a restriction of food intake. There's an intense fear of gaining weight, of becoming fat. They continue to engage in the behaviors despite understanding that they're underweight, and their self-image is significantly distorted. So whereas the rest of the world sees them and sees how potentially emaciated they are, they still view themselves as overweight or fat. So think about it this way: how easy is it for you guys to skip lunch? Right? I know if it gets to like 2, 3 o'clock and I haven't had lunch yet, I'm not as pleasant to be around, right? These are some really smart and strong-willed people, because they are ignoring every signal their body is sending them to nourish themselves, right? Folks in this category tend to be really smart and really driven, which makes it harder for them to be identified. So whereas with substance use disorder, we're picking up on these kids in middle school and high school because they're engaging in not so pro-social behaviors, right? So they're easy to say, something's going on with this kid, right? There's something, and it could very well be that they're using, right? Because they're engaging in all these behaviors that bring attention, negative behaviors that are drawing attention to themselves. Think about folks with eating disorders, particularly anorexia. These are your star students. These are kids who are getting straight A's. These are kids that are involved in in sports. These are kids that are president of the student council, right? These are significant perfectionism, which doesn't hit the radar of the social workers or the counselors at school, right? These kids aren't a problem. So it's not until the disease progresses pretty far where it becomes more obvious that there's something going on from a physical perspective that that kids get identified. Binge eating disorder. So binge eating disorder is, like the name implies, eating a large amount of food in a discrete period of time. Usually, that is a larger amount of food in a shorter amount of time than most people eat in that similar amount of time. The behavior that binge causes intense distress, right? And there's a feeling of a lack of control, out of control behavior, a lot of guilt, a lot of shame. And to be diagnosed as having a binge eating disorder, these binges have to occur at least once a week for at least 3 months. And then we have bulimia. Bulimia is when it's often referred to as binging and purging, right? So again, that binging that occurs similar to binge eating disorder, also having that lack of control during the binge episode, also having the guilt and the shame and feeling numb afterwards, then that person will engage in what we call compensatory behaviors. They will use methods to get rid of the calories they just consumed, right? So probably the most well-known is self-induced vomiting, but there are other forms of compensatory behaviors, laxatives, diuretics, exercise. So these are all ways of the idea is that they're engaging in a behavior that's trying to compensate for the calories that they consumed in that binge episode. So and all of these compensatory behaviors can come along with some pretty serious risks if done often enough, right? And then we have this one. I'm sorry, this slide's a little bit wordy, so you can go back and review it when you want. But when it comes right down to it, ARFID, or avoidant restrictive food intake disorder, is picky eating taken to an extreme. So often we see this develop in early teens or preteens, where they will develop an aversion to all but a very select number of foods. My son's 11. He loves mac and cheese. He loves chicken nuggets, right? But you know what? He'll eat broccoli, and he'll eat pizza, and he'll eat sushi on occasion if it's the right kind, right? Someone with ARFID will, for a number of reasons, will take that selected, I really like these foods too. I will only eat these foods because there's something about other foods that causes anxiety, right? Or an aversion. So when you take that to an extreme, when someone is just eating mac and cheese, they're going to have some significant nutritional deficiencies, right? And may need to have supplements like Ensure or things like that in order to meet their nutritional requirements, because they're not getting their nutritional needs met by what they are choosing to eat, and to the exclusion of everything else. Now, a couple of exclusionary things there is that there are sometimes there are cultural norms around types of food you can and can't eat, and that's okay if that's part of that. If it's appropriate for their cultural dynamic, it's not ARFID. If there are other medical issues that are causing these sorts of aversions, that has to be ruled out as well. All right, and then the catch-all, right? Because there are folks that will not meet diagnostic criteria for these other 4 eating disorders for whatever reason. So a good example of this is, so with anorexia nervosa, you have to be under a certain percentage of ideal body weight to be diagnosed with it. Now, if you have an athlete, right, who is severely restricting their food intake but has a significant muscle mass, gymnasts, runners, things like that, they may not reach that lower percentage of ideal body weight. So it would be atypical anorexia, right? It could be someone who just purges but doesn't binge, someone that is consuming, their binges are occurring solely at night. So it doesn't, so this is a category for people that don't neatly fit in the other categories, because, with the DSM and ICD-10, we need to categorize people in order to, do things like insurance reimbursement, stuff like that. Anyways, so some of the things to look for. So there are physical changes that occur when you restrict your food intake, or when you're purging calories out of your system. For someone who is of a low body weight, women will stop having their periods, right? Because you have to have a certain nutritional intake in order for that biological process to occur. Fatigue, muscle cramping. So if you're malnourished, one of your key nourishing factors is your potassium level. If you've ever engaged in a lot of running and things like that, if you watched a marathon, you'll see people grab bananas along the way, because potassium is what fuels your muscles, right? This will become important as we talk a little bit about the more extreme things that can happen. So if your potassium levels is being depleted, you'll experience muscle cramping, sleep disturbance, dizziness, all these things, muscle and organ atrophy. If you're not nourishing your body's not able to replenish cells, right? Doesn't have the fuel to do it. It can even result in brain atrophy, right? Folks that are malnourished, their brain will get smaller. Hair loss, decreased tolerance for cold. I mean, if you, sure sign of an eating disorder is someone that's wearing oversized sweatshirts all year round, right? All the time, everywhere. Some emotional behavioral changes, decreased concentration, apathy. I tell you, I would rather treat a stone cold heroin addict from Cicero that's gang involved, angry as all hell, than a 14-year-old anorexic. It is like trying to engage with a brick wall, right? There's no affect there. There's very little engagement, because here's the thing. Their brain's now malnourished, right? They are not firing on all cylinders, right? So anger, irritability, depression, decreased self-esteem, social withdrawals, highly sensitive to criticism, and then obsessiveness about food and portions and recipes, and a lot of their discussion, social discussion, revolves around food. So these are all things to look at. And if you notice, a lot of these things very similar to when someone's using, isn't it? Right? So it's if you're dealing with someone that has both issues, and as their detox and their stabilization progresses, yet they're still having these kind of disturbances, 60, 90 days out, or some of these other changes that are occurring, these other behaviors, it could be a clue that you're dealing with someone who has an active eating disorder. So screening, all right. So generally speaking, it's, if you're able to get someone to engage in the discussion around their feelings around food, right, and food intake and these behaviors, generally, if you're looking at the frequency of the behaviors, so say frequency of the purging behaviors, binging and purging pattern, how long it's been going on, you put those two together, and you'll get an idea of the severity, how severe of an issue you're dealing with. So someone that is binging and purging once a month and has been doing it for the past 2 years, severity is probably not too high. Someone is binging and purging 4, 5, 6 times a day, every day, and has been doing so for the past 10 years. That's going to be a much more difficult cookie to crack. So how many of you are familiar with the CAGE for alcohol or drug use? The CAGE is it's a 4-question screening tool, real simple, right? C stands for concern, and so that's the idea is that if you have a And if it's got feathers and it's quacking it, then it might be a duck. These are some questions to ask. This is a quick screening tool. So do you fit this one is called the scoff. This one's for eating disorders. The cage, if you're not familiar with it, look it up online. It's a four question screening for substances. Anyways, so the S stands for sick. Do you make yourself sick because you feel uncomfortably full? C is for control. Do you worry about you've lost control over how much you eat? Now this was developed in England. So if you're recently lost more than 1 stone. Stone is a measure of weight that originates out of the UK. 1 stone is 14 pounds. And then do you believe yourself to be fat when others say you are thin? Would you say food dominates your life? If someone answers yes to 2 or more of these questions, they need to have some further screening. They really need to have someone, you need to have someone to kind of take a look at that a little bit closer. And that's when you reach out to folks like Jen, right? Like Shannon Stowazer at Alexian, who are your, and there's a number of great resources. That's the great thing about DuPage County. There are a ton of great therapists that specialize in working with eating disorders, right? If you ever need a referral or want to know who the great people are or the people to avoid, give me a call. Happy to let you know. A lot of them are my friends, and I'm happy to refer to them because I know they do good work. Anyways, so some other behavioral or physical observations. So someone wearing oversized clothes, right? That's one thing. Overly tight clothes, wearing layers or apparel that's not appropriate for the season. Constantly complaining of being cold, or they look a little cyanotic, right? Cyanotic is, when their lips are a little blue, their fingertips a little blue, circulation is poor, because you know what? When you are malnourished, your body will try to consolidate resources by keeping your blood flow, taking blood flow from your extremities to keep it in your core where it needs to be for survival, right? Noticing need for bathroom breaks, particularly after meals or in the bathroom an extraordinarily long period of time, right? Most eating disorder programs or therapists are, especially if there's, when someone has an issue with purging, are going to do some observation post-meal, right? Have someone sit with that individual for 30 to 45 minutes after they eat, because you know what? By that point, your stomach has done some dumping into your intestines, and purging isn't going to do anything. Then constant need to get water, or they're constantly have a Red Bull or a Monster in front of them, but not necessarily food or snacks, right? Bringing food places like work, but never eating it. I'll give you an example. So I used to work at Linden Oaks way back in the day, and I worked in the intake department, and we had a supervisor there at the time. So my supervisor, person who hired me actually, and I'm not going to name names, but what I would see is that she would bring her lunch to work and sit at the desk and surreptitiously, she thought it was surreptitiously take the bread from the sandwich she brought and put it in the garbage can. Yeah, needless to say, that individual wound up in treatment, needless to say. I mean, but it's, it just goes to show you that as a field, there's a lot of us that are dealing with our own issues as well. So so it's, if someone is bringing food but it's not getting eaten, or they're at Thanksgiving dinner, they're pushing a lot of food around the plate, so they have a mishmash, but it's a mishmash of all the food that they put on their plate, right? Trying to make it look like they've actually eaten some of it. And then inappropriate portion sizes is pretty big. So it's, I really kind of hate the person that developed those teeny tiny little Tupperware containers, because they're meant for things like salad dressing, but that's what they're bringing there. This is my protein for today, and it's 3 almonds, right? Dental issues is a big one. it's fairly easy to spot someone who's engaged in long-term self-induced vomiting because their teeth are gray. It wears away the enamel of the teeth, and they tend to develop some pretty significant dental problems over time. You just can't have that much stomach acid going through your mouth without it affecting your teeth, right? Thinning hair, because again, you need particular nutrients for your hair to grow. And for when you're becoming malnourished, your body is trying to conserve heat in any way it can. So one of the things that happens with anorexia is they develop what's called lanugo hair, which is a downy hair on the face, because you know what, your body's trying to retain some heat. So it starts sprouting hair in places that normally it wouldn't. Skin tends to be dry. You might start to see some swelling of the glands, particularly for those that are purging. The parotid glands tend to get swollen. Difficulty sitting down during meals, constantly checking themselves in the mirror or with hands. Did I just gain a little bit of weight? Better check. How much can I pinch, right? So here's where things can get really dicey for folks with an eating disorder is and when really acute intervention needs to take place. So we know when acute intervention needs to take place with someone with substance use, right? Overdoses, someone needs a detox, they need to be medically monitored. So these are some of the things that we look for in terms of an eating disorder where someone needs to be medically monitored, that needs to go to a place like Linden Oaks or Alexian, right? Is their ideal body weight. And I really hate the term. It's a stupid term, but it's the term that we have, is less than 75. They're less than 75% of ideal body weight. So the way that's defined is that for women, it's at 5 foot tall, ideal body weight is 100 pounds. And it's plus or minus 5 pounds for every inch above or below that 5 feet. So if someone's 5'4", ideal body weight is 120 pounds. Stupid. Hate it. It was developed a long time ago, but it's a tool that's used, and it's a tool that the insurance companies use to determine whether or not what level of care someone's appropriate for. So for men at 5 foot, ideal body weight is 105 pounds, and it's plus or minus 5 pounds for every inch above or below. So if someone is 5 foot tall, 100 pounds, 5 foot tall, and 75 pounds or below, that's an indication of severe malnutrition. Right. Another indicator is using body mass index. Again, another measure that is way outdated, but again, it's a measure that insurance companies use to approve or deny levels of care. So when you have a BMI of less than 16, that's a good indicator that someone is in need of more acute intervention. When I was at Alexian Brothers, and I'm sure Jen can tell some similar stories, we treated people with BMIs as low as 9 or 10. And if Linden Oaks or Alexian Brothers can't stabilize someone medically with that eating disorder, their only choice really is to go to a place in Denver called Acute. That takes the most severe cases in the nation. Another indication is dehydration. Easy way to tell if someone's dehydrated is if you pick up their hand and you tent their skin. If it doesn't pop back, if it stays tented, it's a good indication that they're dehydrated. Electrolyte disturbances, when you're in particular with someone who's purging, it's very easy for their electrolytes to get imbalanced. Cardiac issues, particularly cardiac arrhythmias or bradycardia, right? And then physiological instability. So these are, we're looking at when we're determining whether or not someone is at medical risk, because here's the thing. Someone can look perfectly normal and be ready to code, particularly those with bulimia. Right? Anorexia, it's a little bit more obvious because they're malnourished, they're emaciated. Someone with bulimia can look perfectly normal weight and their lab work is a mess. So the only way to tell whether or not someone is in medical crisis is to get lab work done, right? They need to get an EKG to see where the heart rhythm is. The thing is again, when you're malnourished, particularly with anorexia, your body will slow down processes in order to conserve fuel. So it's not unusual to see someone with a heart rate at 45, 40 or below, right? So when you get a heart rate that's under 50, it's very concerning, right? When you get down to under 40, under 35, your heart can just stop, right? There can also be abnormalities in heart rhythm that's caused from malnutrition or from purging behaviors. In particular, purging behaviors can cause rhythm abnormalities from a heart standpoint. You want to look for what their potassium level is. Again, potassium is the fuel for your muscles, and the most important muscle in your body is your heart. So if you have a potassium level that's under 2.5, under 2, someone's at real risk and needs supplementation at that point. There's other stuff we look at, but those are the big things. Okay. So if you have a concern that you've done a scoff, someone's engaging in these behaviors, someone is, if it's got feathers and it's quacking like a duck and it's paddling furiously under the water, get them some lab work. Get them checked out, because medically speaking, these things can go sideways very, very easily. I'll give you an example of someone I saw and assessed when I was working at Linden Oaks. Previously had gone through the Linden Oaks program, came back after relapsing on alcohol, right? Because she had alcohol and she had bulimia. What we didn't know when she got settled in the assessment room is that the water bottle she brought with her was full of vodka. And right there in the assessment room, she, because of the repeated purging, self-induced vomiting, she developed what are called esophageal varices, or weak spots in the throat, right? The thing about esophageal varices, if they burst, which it did for this poor woman, unless you can get some immediate within minutes medical attention to cauterize those varices, you can bleed out, which unfortunately is what happened. Even though that Edward Hospital is a couple hundred yards away, there's nothing that could be done, right? So it's not just about the weight, folks. It's really these folks can be some real medical danger. And if you're concerned that something might be happening in regards to that stuff, and I know this is heavy, guys. I know it's heavy, but we deal with heavy stuff on the substance use side too, right? This is just a different form of heavy and a different form of how we need to take something seriously and look into it. So some concepts to remember in therapy. These folks have trouble and struggle with having normal interactions. A lot of them just want to people please. It's very easy. That's why this particular disease progresses so far, because they're really good at presenting themselves as the perfect patient, the perfect child, the perfect spouse, the perfect community member, right? They are so good at lying. They're so good at it. They put a lot of our substance use folks to shame when it comes to lies, because they can back it up with, with their positive behaviors, right? They'll lie to keep you away. They'll lie to draw you back in. Which, if it sounds like the push and pull of a personality disorder like borderline, yeah, a lot of folks that have advanced eating disorders, often about 50% of the time also have a personality disorder as well. This is a disease that often crops up in preteen, even younger. I mean, we're seeing it younger and younger. right? The body distortion, right? The unrealistic expectations that start developing that obsessiveness sort of thinking that, progresses into high school, and, some serious restricting. There's the social media around this is horrendous. The pro anorexia sites, the pro bulimia sites, they call it pro ana, are ways that people can successfully engage in these behaviors. The guidance that's available online is horrendous. It's horrendous. It's out there, and our young folks are finding it. Now, here's the thing about eating disorders too, is that there's a certain percentage, and we don't really have a good idea of why this happens, but there's a significant percentage of people that have an eating disorder behaviors in their teens, that in their early 20s tend to have some spontaneous remission. Why is that? We can speculate whether there's because it's not unusual to have second or even third generation eating disorders in a family household, that they get out of that environment, right? That they get away from particular pressures, that the need to be perfect, right? That they then, have some spontaneous remission of their behaviors. However, for those where the behaviors persist into their 20s and into their 30s and 40s, those folks become extraordinarily difficult to treat. Which is why the earlier stat about the older folks have a higher, if the disease persists for 10 years or 20 years, the mortality rate gets bigger and bigger, right? And just like the substance use, shame and guilt are driving emotions for these disorders. So it's what keeps it going, right? Distorted thoughts, distorted perceptions, shame, guilt, just like with our substance use folks, it's what's driving the bus. All right, so I've thrown a lot of information at you guys, and just like I said, a general overview. Some things to consider too is that if you have someone that looks like that they might be engaging in eating disorder behaviors, find someone who knows what they're doing, therapeutically speaking. Like I mentioned, in DuPage County, we have some really rich resources available to us for folks with eating disorders as far as treatment professionals. This is a disorder that takes a team, though, right? Therapist is one piece of it. The primary care physician is another piece of it. And unfortunately, our primary care physicians don't do a great job with this stuff. They really don't. In fact, sometimes primary care physicians are the ones who say, you could really stand to lose 5 or 10 pounds, right? That just kind of drive home the nail of that distorted body image that they might have been suffering with for a little while. Psychiatrists can also be helpful because of the emotional states that often go along with the eating disorder, depression, anxiety, obsessive compulsive disorder. But you got to get a doc that knows what they're doing, right? Because a lot of these folks will absolutely refuse to take an SSRI because of the weight gain, right? So you need to have a doc that knows what they're doing and knows how to engage with these folks with medications or treatment modalities that'll help provide symptom relief for their depression or anxiety or OCD, but aren't going to result in worsening the disorder. And really super important part of the team is a dietitian, and a dietitian that knows what they're doing. Most dietitians out there are great when it comes to things like diabetes, right? Or other weight management, but I'll tell you, it's a real specialty to have a dietitian that has knowledge on how to work with folks with eating disorders. We have a couple of great ones in DuPage County, and there's some that don't know what they're doing when it comes to eating disorder. So it's, again, we all have to be careful consumers about the people we refer to make sure that they're going to be helping with the issue rather than making it worse, right? So with that, any questions, comments, concerns?
Yeah, Don, thank you. If anybody has any questions, you can put up, raise your digital hand and I'll get you in. I just wanted to start off, thank you again for presenting. As I mentioned at the beginning, because this area was a bit of a blind spot for me personally, I was like kind of doing some research over the past few days, just looking online, kind of cursory to see what type of materials were out there. And that same thing you mentioned, which was like eating disorder, um, social media groups. And I was flabbergasted by, first of all, the amount of them. There's quite a few pockets of those on every single social media. But also the kind of like encouragement in those groups. So there'll be people who post photos of themselves, incredibly underweight, um, looking very, very unhealthy. And the comments underneath it will be, you look great, keep going, you can lose more. And it was like a very scary situation when I was looking at those things.
Right.
And I think with the age group that is really spending so much time online like that, that has to just be fueling it.
Absolutely. And if you think about it, think about the pro substance use sites that are out there, right? Especially around psychedelics. I mean, if you want some support on what you're doing, you'll find a tribe online to support you with what you're doing. Bruce, you had a question.
Yes, I think that one of the bigger problems is insurance coverage. I had asked Jen, and she said they take traditional Medicaid. So I mean, and I was in the field for quite a long time. The biggest thing was couldn't find anybody to cover it.
Mhm.
So we could have all these theories, and without any kind of treatment, we're
Right.
just reading books.
Well, fortunately, there's, with if you need a resource, right? Folks like Jen, Shannon at Alexia, and myself, we're happy to point you in a direction. So, for instance, the Medicaid thing, huge issue, huge issue. Folks with Medicaid couldn't get any sort of treatment. Fortunately, Ascension opened a unit at St. Joe's downtown that takes Medicaid. So now there's an option for them, right? But that's for acute care, right? And there are some places that will take Medicaid for PHP or IOP. Far and few between, much like the substance use world, right? Medicaid, a lot of doors are closed to folks with Medicaid or managed Medicaid, but there are resources out there, right? There's programs like organizations like Project Heal that will fund treatment for eating disorders. So the point is consult, right? If you're struggling with finding a resource for someone, there's people in this group or people that know people, the people in this group that know people outside the group, so to speak, can help navigate some of that stuff.
Thank you for the question, Bruce.
Thank you.
Thanks, Bruce. Did that answer
Any
your question, Bruce? Was that?
Yeah, I mean, I understand it's getting better. It's just, kind of a shame that sometimes for the poorest, sickest people, there is no treatment, and then clinicians end up trying to help when they're not really qualified to do that.
Right. And that's the scary thing about it, is that it's, you have treatment programs, residential programs, they'll say, oh, sure, we can handle eating disorders, and don't have something as essential as a dietitian on staff. Be very careful about where you send your folks if they have an eating disorder as well, comorbid with their substance use. And, insurance companies are, they restrict care more and more and more. People who used to be a slam dunk, inpatient now are getting pushed down to PHP or even IOP because insurance won't cover inpatient or residential. Ben, you have a question.
Yes, thank you. Thank you for your presentation today. It is a thing that is really, I think, vastly overlooked, and obviously from what you present, not a lot of treatment out there. What I'm curious about, well, how do I say this? My wife is an English professor at Bradley University, and she chaired a program called the Body Project, that was supported by the National Eating Disorders Association, NEDA. I don't know if you have any commentary about that, if those sort of things are helpful or
It's raising awareness. So NEDA, National Eating Disorder Association, they're primarily an awareness type of organization. Their goal is to raise awareness around eating disorders and eating disorder behaviors, that, if someone's suffering, that there's help available for them, things like that. So, Body Project is something that's going on campuses all over the nation. It's no different than some of the awareness campaigns that go on around substance use. If we don't know about a problem, if we can't say, look at a neighbor and say, wow, that person's not looking well, right? Look at our friend and go, boy, why are they in the bathroom for a half an hour every time we go out to eat, at the times that they actually agree to go out to dinner with us, right? If people aren't aware of what it looks like, they won't know to ask the questions, right? Or to show the concerns or offer support. So it's NEDA's been doing this work for a long time. There's some great organizations out there. There's a group called ANAD, which stands for Anorexia Nervosa and Associated Disorders, that provides support groups for folks with eating disorders and their loved ones, their significant others. They tend to be they're different from 12-step. They tend to be led by a therapist. Be cautious though, because there's a lot of good ANAD meetings, and there's a lot, just like 12-step meetings, right? There's a lot of good ones, but when they're toxic, oh boy, are they ever.
Yeah.
So
yeah. It does seem like self-help groups have the possibility of being helpful, of having people with a common concern come together, but it's duly noted how they can absolutely go wrong as well. But
so it's just like anything else, is walking alongside with a therapist that can help guide you and identify
yeah.
when a self-help group is going to be helpful for you. There are a few meetings for Eating Disorders Anonymous that takes more of a 12-step approach to an eating disorder.
Yeah.
There's a lot of controversy on, eating disorder as an addiction. A lot of controversy in the treatment community around that. Here's the thing: it's that it's hard to, when you have a treatment community that can't even agree on the concept of recovery versus recovered. There's a lot of strong opinions, and for lack of a better term, and I apologize if there's any eating disorder clinicians on this Zoom right now, but there's a lot of clinical arrogance in the eating disorder treatment community. So it's a tricky. I love them. Believe me, I love these people. I love the community. There's a lot of really good work going on. These are you'll be hard pressed to find a case as clinically complex as someone with an eating disorder.
Thank you, Don.
Thanks.
I think Jen put in the chat, Linden Oaks hosts ANAD support group in Naperville on Monday evenings. And so that is an open group, and it is led by a therapist. So that sounds like a nice setup over there. I had a quick question. So as someone with lived experience, I have been through the Linden Oaks detox a few times. And I always remember like going to meals sometimes around the same time the eating disorder inpatient group would come. And I kind of noticed that, like, for a majority of the group demographics that made up that group, this is anecdotal, did seem to skew much younger. Is that what you see generally? Is it something that skews younger?
Yeah, generally speaking, it's going to hit the younger. There's going to be a greater volume in the younger population than the older ones. Again, talking about that spontaneous remission, it tends to hit younger people more, so to speak. You're going to see more of them. One of the issues too is that it's also very underidentified in socioeconomic populations that are not white, middle, and upper class. Right? Because eating disorders hits every strata of the socioeconomic spectrum. And it doesn't discriminate by race either. It's just that they're far fewer are identified or seek help for that matter. Danielle, you had a question?
Hi, I was just curious if you've ever noticed a like trend with people that maybe use like semaglutide or like Ozempic or anything like any of those kind of like weight loss medications that they're using for weight loss now. If there's ever been like a trend with that.
So it's boy, semaglutides, boy, that's some controversial stuff right now, especially in the eating disorder community, because there are, is it a compensatory behavior, right? Is someone preemptively purging calories that are never ingested, right? Um, there's been some evidence, and there are actually some treatment programs that are using semaglutides for folks with binge eating disorder, because their experience is that it helps quiet that noise that pushes them to binge. We are in our infancy when it comes to understanding the impact that this stuff is going to have. What we do know is that when you stop taking it, you tend to have a rebound, right? Just like any other diet. It's, unless there's some significant lifestyle changes that go along with using a medication like that, when you stop taking it, the weight comes back. So yeah, there's not a lot of good. We are still collecting information about this stuff, and my own personal opinion is that I think we're going to see some consequences long term that we weren't anticipating.
Don, I have one last question, and then if anybody else has a final question, feel free. This might seem like an obvious answer or a dumb question, but with the intersection with substance use specifically, do you find that the substances kind of abused the most as stimulants for people who are also with eating disorders?
Stimulants and alcohol. Yeah, people drinking their calories because they're empty calories. So if there's no food involved, those empty calories get burned, but there's nothing kind of behind that will then result in, fat cells being generated or expanded. So, yeah, and we tend to see more substance use with bulimia than the other disorders. That tends to go, there's a higher incidence of co-occurring with bulimia than there is with anorexia. But again, it's there with anorexia too, particularly with, Adderall, your stimulant medications, less so things like cocaine, but stimulant medications tend to be more highly abused.
Thank you. Any final questions for Don? Going once, going twice. Don, thank you so much for the presentation. Incredibly helpful.
There's my
Yeah,
contact information. If you need, I'm always happy to consult. If you have a question, if you have a concern about someone, shoot me an email, give me a call. Because like I said, it can be life-saving if it gets addressed. And it can seriously complicate someone's treatment if it's not identified and not addressed.
absolutely. Just a quick housekeeping note. Next month, we are taking a little break from our presentation series for the holidays, but we will be back on January 8th. And actually, our friend Bruce Seawick, who's in here with us, will be presenting on the psychedelic renaissance and what it's being used to treat trauma and a number of mental health challenges. And if you were able to attend that a couple of years ago, it's been about 2 years since Bruce did that presentation. He's got some updates here and there, but if you've never attended it, it's a fabulous presentation. And we really look forward to that. So Bruce, we look forward to having you in January, sir.
Bruce,
It's always a pleasure and an honor to be part of the dissemination of knowledge. Thank you very much.
we need to talk, buddy.
Okay.
Yeah, we utilize ketamine and Spravato in our practice, so love to pick your brain a little bit.
Okay.
All right, y'all. Thank you very much. And this will be up on YouTube so everybody can share it. And thank you again, Don, and everyone else. Have a wonderful rest of your day.
You too. Thanks.
Thank you,